Vinay.
Yes, sir, please go ahead.
Yeah, we'll talk about the endoscopic and minimal invasive spine surgery because as every field has got a minimal invasive spine surgeries, so we got also in the work in the spine also. The advantage for this spine surgeries when we do a minimal invasive is because there is a less blood loss. Second is that hospital stay is very less and it's very pain is less and the healing is faster. So that's why we are starting doing this kind of surgeries. First, we do a percutaneous discectomies. They are the different modalities. We can make lie down the patient sideways or prone. We can do the surgeries. When we do by these surgeries, we see this kind of tissues. We remove the disc by percutaneous methods. These are the anatomies. We can see the ruptured disc and free the nerves. These kind of discs are very good for the contained disc when the disc is not extruded in the spinal canal. If the disc bulge is there, which is compressing on the nerves, these kind of endoscopic surgeries are very good. Second is a kyphoplasty. Why we do kyphoplasty is for the compression fracture of the spine. Whenever I'll show. This is the, you can see the disc prolapse here, which is compressing on the nerves, L5, S1 level. This is how will, if you see this nerve root is compressed on this side, right side, you can see this nerve root is compressed. We'll go by do a surgery. This is our setup. This is the video of surgery I'm showing you. We put a retractor here. By this small retractor, we can proceed with the full surgery. Initially part we have to do small tissue we have to take. This tissue we have to remove. Then we drill the bone and we reach to the, now we are reached to the disc level. We are cutting the disc, annulus of the disc by retracting the nerve root. Yeah, we have cut the annulus. Now we are taking the disc out. By this method, we can, this is the, now we are removing the extruded fragment under the nerve root. So in this case, we are seeing this bone has collapsed. This is osteoporotic fracture, which usually happen in the old days when the bone by the trivial trauma, mild fall, or even by the severe movement or sometimes the coughing and sneezing, patient getting the collapsed bone. It is quite painful. The old method, as you know, we make the patient to lie on the bed for 2 to 3 months and we give medicines to heal this bone. But because the most of the patient which are the old can't lie down absolute bed rest in the bed for 2 or 3 months, or they want a mobility to carry on. And the pain, we want to reduce the pain. So what we do, we put by percutaneous injections and we put a cement in the bone. As you can see, we have filled all of the bone with the bone cement. This makes a kyphoplasty. More than 90% pain goes on the next day and we can mobilize the patient from the next day. This is the advantage. But some, as you know, there's an advantage. Some contraindication for this surgery are, one is that if there is an infection, we can't do it. Second is, if there is a retropulse fragment, if the this bone fragment is here compressing the nerve, we can't do, because as we do kyphoplasty, this compression may increase or dye may leak out in the spinal canal, which can cause paraplegia or nerve damage to that. These are the cervical disc problems. As you know, multiple disc problem is there, maximum in the 5-6 levels. So now what we are doing is the disc replacement. So advantage of the disc replacement are that the number one, we can restore the movement at the same segment, which has been restricted. Otherwise, if we are doing the ACDF, when we do some graft and fix the bone, there is some loss of the tissues there and the mobility is reduced and the problems comes with the after some times, like this adjacent segment disease. This might degenerate and lead to the problem. But the advantage with this that mobility is maintained. So adjacent segment disease chances become very less. This you can see is the tumor here. This is in the paravertebral neurogenic tumor is here. As you can understand, this is a large tumor. We planned by which route we can operate this tumor. Because if either we go from the spine only or we go by the retroperitoneal approach, then we require big incision to be done for this surgery and it's difficult to remove. So we have done by this minimal invasive approach by small incision. I'll show the video. We make a small incision in paravertebral region. We put the dilators, as you can see here. Once the dilator and the system has been placed, this you can understand about around 2 centimeter incision. This initially we have to some tissue we have to remove above the bone tissues. Okay. Now we have reached the tumor. You can see tumor is a very vascular. Now tumor is between two true transfer processes. So what we do, we nibble out some of the transfer process to make the space wide may make space widen. As there is a bleeding, we try to coagulate, which is the bleeding point there. And we have removed tumor in toto, majority of the tumor, but it's not coming out, so we have to remove in the piecemeal. So now you can see this tumor is coming out. Now we are cutting the attachment. First we have coagulated it and then we are cutting so we can deliver the tumor out. So now we can see this is the nerve root we can see here, preserved nerve root. This is the mainly advantage that by the 2 centimeter incision we have removed the completely tumor and preserving the nerves. Otherwise this surgery is very difficult to do. Now I'm showing this cervical disc replacement. How we do it? We have opened from the anterior cervical space. We have opened this. Now we have removed the disc. We are putting 2 pins and we retract by this. So disc space can increase slightly. So once we have removed the disc, we have to take the advantage that that disc is completely removed and the posterior osteophyte we have to remove. Then we see the size of the disc by measuring the size. Now we are putting the disc. We are using the Bagheera disc. It is Spine Art company which make it. There is, you can see the spikes on the disc which make it to hold with the vertebra. Once we have placed this, now we can check the movement. You can see there is space in the disc is increasing or decreasing. So by this movement we can check this is nicely placed and the movement is adequate. So advantage is that we have removed the disease part and with preserving of the motion segment. And the advantage is that post-op patient need not to put the collar for a long time. This is another case of the spine where we need do a minimal invasive. This is the fracture of the spine of the odontoid process. As you know, here we can see this is almost aligned, but as the movement occurs, this fragment of the odontoid moves forward and this remains the same. So this kind of the fracture either we can fix from behind by doing surgery, but we have to open too much and the fix from the behind. But now we are doing the percutaneous method or by minimal invasive. From the anterior we put a screw here. I'll show how we do it. This is the screw placed between the two. So it makes a bone and internal fixation. By this we can make it heal. Even we can remove this screw after 3 months or 4 months. This is the another disease segment is here. This is atlantoaxial dislocation with the tissue, abnormal tissues coming here, which is compressing the thick segment, and this C1 arch is moving forward. In this case, we have to do two surgeries. From the mouth, we have to remove this portion called venous, or this tissue abnormal we have to remove without dentire. So we can free the tissue from here. And then second stage, we need to fix this from behind. I'll show how we do it. This is the intraoperative X-ray. After removing we have done this. I'll show the video how we do it. This is the positive fixation we have done. This some part of the brain I'll do endoscopic third ventriculostomy. We are doing for a lot of times. Now we use for this complex hydroscope. It's a multiloculated hydrocephalus or intracranial cyst. Endoscopy we are using in the tumors, in the pituitary tumors, in the transpinadal surgery or microvascular decompression. These are the presentation. By we make a small burr on the skull. The endoscope is guided through a foramen Monro, and this is the diagrammatic representation of what we do. This is the floor of third ventricle. We make a small hole in the third ventricle because usually the blockage is here in the aqueduct. So we can bypass this and relieve the hydrocephalus. These are the landmarks which we see. This is the choroid plexus here. This is foramen. This is the membrane which we make the small hole here, and this is the dilate. We can do this. Colloid cysts are the small benign tumors, cystic tumors at the junction of the lateral ventricle and third ventricle, which is obstructing the passage of the CSF from the lateral ventricle to third ventricle. These patients are present usually with headache and sudden dropout attacks. These carries high mortality. Sometimes patient raised ICT and fall down, and they never regain the consciousness, or they die in that area. So once it is that, if you find the colloid cyst anywhere, please remove it. Do by surgery or endoscopic, whichever you have, or better to do by endoscopic because it causes small incisions. Risk is very less. We can decompress or remove the colloid cyst incomplete. So I'll show the video. This is the colloid cyst here and lead to the ventricular dilatation. Here you can see third ventricle is not dilated, lateral and the lateral ventricles are dilated because it is a wall-like mechanism which is blocking the both the foramens. So fluid is not passing from the lateral ventricle to third ventricle. So, this is, we have made a small burr hole. Now we are putting the endoscope in the lateral ventricle. Now you can see this is choroid plexus. This is a septum which is thinned out, but still it is there. Now you can see the flimsy layer is the septum. Second, you can see there we can't see the third floor structure because it's blocked. Now first we do is by making a hole in the septum so that both the ventricles become one. The advantage is that this is the colloid. After puncturing the colloid cyst, we are aspirating this colloid material from there. First, we do decompress the cyst by suctioning out the colloid material from there. Once the colloid material is sucked out, then we, with the gentle suction, we bring the colloid cyst into the lateral ventricle and remove it. Now we are removing the cyst wall. As you can see, tissues are coming in the suction. So now after removing, you can see the third ventricular structure from there. Now with the help of, we are trying to know any remaining portion is there or not. But now you can see the opposite choroid plexus. So we are coagulating it with the cautery. Now you can see the beautiful third ventricle structures, the floor of the third ventricle. So we have removed adequately the colloid cyst, and this is a wonderful surgery because by small incision we can remove this cyst with a good result. This is another case. We are seeing the colloid cyst. This is the post-op scan. You can see there's no colloid cyst is seen here. This is some remaining post-op tissue is there. Now another surgery part is the stereotactic surgeries. We do stereotactic surgeries in the biopsy we want to take from the deep-seated tumors. Here we can apply this frame and we take the target in the CT scans by the 3 axis X, Y, Z. So we can localize the point. We make a small hole and by reach that point. So, and second we use in the Parkinsonism where we put an electrode in the uh, subthalamic nuclei. So we use this frame and this is frameless. Here the frame is not there. By this we apply a fiducial markers and by this we can do frameless where we want to put the screws. This is the setup of the neuro navigation guided. When we get under the neuro navigation or half robotic surgery, we get a localizing things. We can remove the tumors, but complete arm is not formed. Only the arm is there to put the electrodes. These are the, you can see fiducial marker. We can localize the tumor and we can remove with the neuro navigation. This help in a complete excision of team. So this is our team, how we remove the tumor with the neuro navigation. This is another beautiful thing is that we are using the all modalities to remove the tumor. Here we can use localize the tumor by neuro navigation. This is, we give a yellow dye. We call this fluorescent dye before the onset of the anesthesia, and during the surgery we find the tumor gives this kind of different color than the, you can see the normal color here, and this is a tumor. By this we can differentiate the tumor from the normal tissue. It can help to remove the completely tumor from the brain. This is the one of the modality, but we need a microscope. There is a special filter to see this. Another is a trigeminal neuralgia. You know the causes of the trigeminal neuralgia are tumor, vascular compression, but it is a very severe pain to the patient. Unless it is not a life-threatening condition, but it causes a lot of nuisance to the patient. Patients are not able to carry out his daily activities, not able to feed himself. Sometimes brushing is difficult. Sometimes eating is very difficult. So these patients initially may benefited with the drugs and other methods, but later on the drugs doses are required too much, which cause the side effects. So these kind of patients comes to us because they are not happy with their life and they are not happy with their medicines. So now we are trying. Hello, any question? Okay, these kind of patients. Now we do a microvascular decompression surgeries. What we do, this you can see the vascular tissue compressing the nerves. Nerves. So we have to find out the different ophenic culprit arteries, and then we localize it.
Basali kuna maternité lobby. Lolo bazaki na reno ko tu be ba ki mabe. Ego yo.
There was an unintended interruption. Please go ahead.
These are once we localize the which vessel is conflicting with the nerve, then we do by this surgery called microvascular decompression. I'll show the video how we do it. Now we have retracted the cerebellum because small craniotomy has been done. We can take help of the endoscope also. So now we are removing the one artery, is big artery has come in between. We have to remove this artery from the first. You can see now we have seen the fifth artery. Now you can see this vessel is compressing here on the fifth now. We have to separate this vessel from there and we put a graft in between that. So we try to minimize the mobilization of the nerves and other tissues. So this is the diagrammatic representation which vessel is compressing the nerves. So these patient gives very wonderful results and their results are very fantastic. We can stop all medication within few weeks after the surgery and patient is totally relieved of the pain. these results are very good. Sometimes if there are the more than one vessel, we have to remove all the vessel from the nerve. Sometimes we have to circumferentially separate the nerve from the vessels. Another thing is a glidal wafer. It is a chemotherapy carmazine implant, because it is a chemotherapy which is given in the tumor bed. If the like the GBM or the firstly diagnosed or the recurrent tumors, what we do when there's a recurrent tumor, we do surgeries. Like you can see the recurrent tumor here, because these prognosis of the glioblastoma multiforme is not very good. So what we do, once we do surgeries, now you can see what it looks like, glidal wafer. So according to weight, we can put 6 to 8. After removing the surgery, we have put surgery cell there. Now we'll put the chemotherapeutic wafers. So they can release the chemotherapy directly in the tumor bed. So it prevents the recurrence of the tumors. It can delay the recurrence of tumors, maybe more than 12 months. So we have used in a lot of patients, because it is a costly affair. So some patient can afford it, but who can afford it, they can buy more time of the life by maybe 1 year, 2 years, 3 years by using this method, because it's not difficult. Once we are doing surgeries, it's easy to place it. You can see this. Now is a focus ultrasound. This is also is in use. We are making incisions, like in the Parkinsonism also, in the dystonia also, we are making incisions, which we can by ultrasound. In the MRI guided ultrasound, we can do, and we can make a focus lesion of the where we want. But still, I'll advise Parkinsonism is best treated by this DBS method, deep stimulating electrodes. We put it like that. Now I'm taking Parkinsonism. As you see, these are the very disabling disease. Patient is not able to walk, patient is not able to feed, patient is having a movement while feeding himself. These kind of things must initially, as you know, the methods, levodopa and other things help in the patient. But after 4 or 5 years, they require too much dose, or they cause so much side effect. Then we have to move another method. That's a deep brain stimulation method. If we put it in, we are using in the Parkinsonism, we are in a putting the dystonia also. Then what we do, this apply the frame. By the monitoring, we can find the subthalamic nucleus by two methods. One is the localization of that. Second, we monitor the waves of the brain. Different waves we can record and find the which one. Third is that by putting the electrode, we ask the patient to perform. Hello. थोड़ी देर में कॉल करवा देगा. By this localizing, we can ask the patient to do movements, so we can see कि patient, this electrode is properly placed and helping the movements. So by this we can do it. Next is interventional MRI, intraoperative MRI of this. We can first in the pre-op we can localize by the functional MRI. What we localize which part of the brain is, we can mark that, and we can avoid during the surgery. Next is intraoperative. In this, we do remove the tumors, and if we have got a brain suit, then we can do intraoperative MRI, and if see any tumor is left or not, or we can remove it. And next is a gamma knife for radiosurgery. These are the small meningiomas, perioptic tumors, vestibular schwannomas, small, and previously residual tumors, AVM metastatic lesion. We can do by this single or maybe multiple seating. We can give high dose of radiation, and we can control or decrease these tumors. This is the representation of the gamma knife. Now is the main thing is the role of the robotic in the spine surgery in newcomers. What are the advantages of robotic surgery is that, number one, the adequate, where we have localized initially placement without failure. Second is that radiation is less used. Third is it is advantage, gives time saving, because the maximum part has been done initially. So I'll show how we do it. This is case of disc prolapse here. You can see now this is the setup of the robotic surgeries. This we have localized where we plan. This is myself. We are planning this. Which size of the screws and which trajectory we are requiring to do put the screws. So advantage that everything we can fix early, and once we guide through the robotic where we want the put the screw will go in that direction. That is the advantage of that. But it's still this is the robotic arm. Through that we make the holes, and we can see the screen where the screw is going. So advantage is that the perfect placement of the screws. So now damage due to the placement of screws is very less, radiation exposure is less. So by this help we can put near perfect screws, but still we don't have the robotic arm to the nerve decompression. And maybe companies are under the process. Once that will be made, then complete robotic spine surgery may come. This is a partial robotic surgery when we have to do the decompression under the microscope or endoscope, and we can put these screws with the help of robot. This is how the screws are passed. So I'll show video of this, how we put and we see on the screws. So it's a real time. This is the, you can see the now screw placement, nearly identical and perfectly placed. This is the, you can see the listhesis has been reduced here. This is a really great. So now I told you this robot is coming because it is a good part to place the screw, because the complication of the avoidance of the malplacement of screws can be avoided and radiation is less. So now we are still lacking the decompression part of the nerves. So now thank you for your patience hearing. And if any question, you can ask me right now.
Thanks, Dr. Anil. We have a question from Dr. Ivan. Dr. Ivan is from Uganda. So his question is, first he wants to thank you, and then question is, can DBS help patients with epilepsy, chronic pain, or psychiatric disorders?
Yeah, we are doing in the intractable seizures, we are putting it, but we are not routinely doing it, because which other methods are still better. We can do find the in the like the epilepsy, if we find lesion in there, then we remove the lesions or do medial temporal lobectomy. Sometimes we do hemispherectomies. But if it's not working and if we are not finding any focus or there, then we can put in anterior thalamus, we can put electrodes. But result, as you know, 70 to 80% it works, 30% it doesn't work. But when there is an interact, even we are putting the vagal nerve stimulator now, if we are not finding any focus and of the epilepsy and it is uncontrollable, then two things, either vagal nerve stimulation or we can do this electrode placement for epilepsy. Second is here, we have done a few cases of the frontal placement of the screws, DBS for that psychotic disorders. But results are plus minus. Sometimes it works. We have patient need to understand because these are not curative. Number one, these are the because can control the symptom and still has to take the medication, and these are results are not 100%. So we are doing with that.
Sir, like you had discussed DBS as a part of the therapy for Parkinson's disease. So, how is the sequence like if somebody is diagnosed? Yeah, Dr. Abdullah has raised a hand. Yeah, Dr. Abdullah, please ask a question. Dr. Abdullah, you can unmute yourself and ask.
Yes, you can continue. I will ask after you. No, not an issue, please.
No, it's okay. I'll ask in the end. Please go ahead and ask.
Uh, Good evening,
Hi, Dr. Abdullah. How are you?
everyone. Yes, I am fine, sir. Thank you. I am Abdullah. I am facilitating for Arab patients as I am an Arabic language expert. Right now, sir, I am communicating with one patient. He's having a query related to DBS. So, as already Dr. Ivan started the conversation and the question, I would like to know if there is any major drawback of DBS over after 10 years or 15 years, as you have.
Major, yeah.
Yes, please go ahead, sir.
Major problem is that if we are not using chargeable battery, we have to change the battery after maybe. Second is if any trauma or something, someday the electrode may disconnect or failure of the electrodes. That may happen sometime. Or another is that we might have to change the settings of the patient. So patient need to frequently visit our country. Some now devices available, we can change the setting on the mobiles from here. But the major problem is the change of the battery, because if the chargeable we need to around 15 years, or non-chargeable we have to use maybe 6-7 years, we have to change the battery. That's it.
Oh, okay, sir. Okay, sir. Thanks for knowing us. Yes, Mr. Varun, you can proceed. Sorry, I cut you short.
No, it's okay. Sir, you had suggested DBS as a therapy for Parkinson's. But generally Parkinson's is also long medication and it deteriorates over a period of time. So when is DBS sequence? Like initially, like what kind of advantage it offers? If you can discuss a little bit more about that.
No, we prefer first give the medicine. We start with the lower dose, then gradually increase the medicine dose to control the disease and symptoms. But once this is the ideal time to do a DBS surgery, when the dose is required too much, their side effects start coming or the medicine effect goes lower down. So that is around 4 to 5 years of the diagnosing the Parkinsonism. These symptoms time come when the DBS is required to abolish the drugs or decrease the drugs. So ideal time is that to do this DBS surgery.
Okay, and sir, like DBS is a costly procedure, right? So
Yeah,
it might be cost prohibitive for many patients.
yeah, because we got around different packages here. It costs in our hospital maybe from 30 to 35,000 dollars here, including everything, staying, medicines, testing, and surgery and hospital stay.
Yeah, so because we had a patient case, like we had consulted you, but the cost was prohibitive for them. The patient was from Rwanda, so that 30,000
Um,
plus many.
because the different companies equipments are differently because available in the country. Few are very costly, few are slightly like non-chargeable is less costly, but we have to change the battery after 5 to 7 years. Chargeable are slightly costly. Now newer modalities where we can do the monitoring also with these are more costlier. So whichever the patient opt for that, we can use that in the different patients.
Okay. Please go ahead and ask more, sir, about the precision and accuracy of robotic surgeries. Basically, so many times, especially in your area, like general population, there are a lot of myths about spine surgery being risky, and when it comes to brain surgery, so there is a lot of fear. But as a surgeon, and many times our doctor colleagues, they have to counter these fears in patients. So if you can like little bit talk about that, how
Now I
safe
tell
they
you,
are.
major complication in the spine surgery is only 2%. One is the life risk, 0.5%, and 1 to 1.5% is sometimes neurological deficit, maybe due to injuries or infections. Not more than that. 98% patient do well, 90% do very well. Problem is that when the persons are operating who are not trained or infection rate is high, that the complication comes. Sometimes the expectation of the patient is too high because he thinks every pain goes off, nerves will I'll become absolutely normal. That is not possible, because when the patient comes to us, it comes in late stage. Nerves usually get damaged, and the bone get deformed. So whatever we do, we can relieve his pain by 80 to 90%, maybe 95%. Some pain will be there, and the majority of pain goes. They can live their life in a better way. But they have to also understand that we are just repairing or correcting the things. We are not making the new one. That is also part. But nowadays, complication of the spine surgery is very less because infection in our, we are operating maybe around 400, 500 spine surgery in a year, but we are not finding infection hardly in any patients. The major and now damage. Majority of the patients are doing very well. Maybe the results may vary. They may be benefited around 70%, may benefited 80% because they don't. Some are expecting that there should be no pain after surgery, but it's not possible. What we have done, we might have repaired 2 or 3 vertebrae. We have fixed them, so they are not normal. They are near normal but not normal. Say they might have sometimes muscle weakness, still nerves changes in that might cause some pain, sometimes tingling, numbness and weakening persisting with the after surgery also. That is a there. But results are definitely good. Which patient are unable to walk, they can walk with pain free and they can carry on their daily activities.
So similarly, myths about brain surgery, sir, like if somebody has a tumor, so as a general populace, they would be that if, I mean, slight off here and I may lose my speech or some mental faculty. So
Yeah,
if you could speak a little bit about, because it can help in counseling, especially you do a
depending.
lot of anatomies, etc. And I see the success rates that are mentioned are very high, but general population thinks different. So if you can a little bit shed more light on that.
Like the brain surgery, mortality during surgery is only maybe 2%, not more than that, 1 to 2%, depending on the tumor. Second is the deficit. Yeah, location of the tumor, if it is in speech area, may have the difficulty in speaking, or may have the where the power of the hand and may weakness comes. These are risk are total risk are 5 to 7%. 93% do very well with the surgery. We remove the tumor, we send biopsy. Next comes is the problem of the malignant tumors, which will may come again because we can't, removing the tumor is not cure. Only the benign tumors or less aggressive tumor can be cured by the removing. Rest we have to give radiotherapy and chemotherapy. Still they come back. That is the main problem. But nowadays surgical complication with the expert hands are very less than 5%, not more than that percent.
Okay.
And
So,
by 1 minute, and by the newer methods that we are localizing under high-end microscope with the neuro navigation and this intraoperative dye, the risk has become very less now.
so there's a follow-up question from Dr. Ivan again. So thanks so much. Today is amazing. How close are we to restoring function in patients with complete spinal cord injuries?
Spinal cord stimulator?
I don't know, sir. The question simply, sir, how close are we to restoring function in patients with complete spinal cord injuries? Dr.
No,
Ivan,
spinal.
yeah, yes, sir.
Now we have to understand the spinal cord complete injuries. These patients are not going to recover completely. Some patient recovers minimally. Uh, Next comes at their symptoms like stiffness in the legs, pain in the legs, difficulty in mobilizing. We have to train to carry out them because if the hands are working, we have to carry out that they can manage their life with the hands, whatever they can. They can use the wheelchair, but sometimes the symptom of pain in the legs. Second is the stiffness in the leg. We can manage by baclofen pump implantation, morphine pump implantation. Even the dorsal cord stimulators sometimes give them better sensation, decrease spasticity. Sometimes with the additional of the physiotherapy, they can regain some power in the legs. So some patient can do with this, but not majority of. So it's a very difficult to say that dorsal cord stimulator will apply, they will completely cover. No, there chance that their symptom will become better. Some patient might recover with some power in the legs, which can help in maintaining their daily life.
And another question from Dr. Ivan is, what role do stem cells play in spinal cord injury management, in spinal cord injury treatment?
Because 1 year I done this project of the spinal cord with the uh, stem cell implantation. We take from the iliac bone and put in the spine. But in the we have done around in 20 patients, one patient showed improvement. But that may be that thing that patient might nerves are recovering by itself for the medicine. We can't say because the statistically we didn't find any significant with the stem cell. So we have discontinued this trial after that. Still, it is not recommended for anywhere in the world. Okay, we do in spinal cord. Yeah, partial injuries, they do better with this. But complete injuries, not a much recovery with the stem.
There is a question from Dr. Ornana Paul from Nigeria. He's first thanking you for the masterclass, and he wants to discuss a patient case. So they just encountered the patient. The MRE found a developing hemang, uh, hemangioma in the cervical vertebrae region. At what point can the patient benefit from surgery?
Hemangioblastoma.
Yeah.
Hemangiomas in the spinal vertebra. It
Yes,
doesn't
sir.
require any treatment for that unless there is a fracture of the vertebra.
Okay.
Because small hemangiomas are benign tumor in the vertebra, they doesn't require any treatment. If it is large enough involving the pedicle or sometimes the fracture occurs or make the bone the weak, then need decompression and fixation of spine. Otherwise, they don't require.
Dr. Paul, you can share the MRI report. So, is hemangioma in the cervical vertebra region? Cervical vertebra.
Yeah, because if it's a small one, we don't require. If it's a bigger one, it is causing the destruction of vertebra, then we need to corpectomy. We have to remove it. It's a very vascular tumor, and we need to put a case and bone and fix it.
Dr. Paul, you can share the MRI report with us. We can share with Dr. Anil. So, based on the size of the tumor, like as he said, that sometimes nothing needs to be required, and if it is big enough, then the intervention is required. Uh, okay, thank you. Sir, uh, basically, I also wanted to talk to you about, since at Jivo what we are trying to make is like the referrals and the medical travel, we are trying to make it doctor led. And as a surgeon, when you treat patients here, so it is this one-time intervention. But many times, if the patient's local doctor is in touch with you through a structured platform like us, and they can share the reports well in advance, they can get guidance, and after surgery, like at the periodic check-ins, the continuity in care can be maintained. So compared to this agent-driven, like we accidentally had a facilitator join. I was thinking I thought that he was a doctor. I had removed him because this forum is only for doctors. So, sir, as a leading surgeon of India, and that too HOD at leading center like BLK-Max, so you have dealt with so many international patients. So, for our doctor community here, can you give a perspective like how their involvement from Africa side is beneficial for the patient and continuity of care by being in touch with doctors like you?
So, like by doing this kind of sessions, you can do. Sometimes you can do also is let like meeting where we talk about one topic, only one topic, and all discuss about their experience.
Okay.
Because giving a lecture, you decide a topic like any tumor or brain tumor. We can all discuss what our experience with it, and whatever we can have a knowledge, we can pass on to them, and can take from them also because they got a lot of experience also. That is one more method that we can plan is that we want to do by one topic,
Yeah.
like open form discussion on this. Second is as we can communicate whatever there's feedback after surgery, patient goes to them, they take note of it, they consult the local doctor, they take feedback, and they can communicate with us whatever they're prescribing, what are the problems they have. So we can guide them when to repeat MRI, when to read CT again, and what we're finding on them.
Okay.
The communication should be more frequent with them. Two things I am right now I'm saying. One is topic oriented, because when we talk a lot about one topic. So better to talk about one topic and share their experience also, what problem they are facing with it.
So in our network, there are certain spine surgeons and neurosurgeons, and I mean professors who teach neuropsychopathology, etc. maybe we can have a outside this masterclass series. Maybe we can have a focus session on
Yeah,
some topic which you can suggest, and we can the relevant doctors can participate, and it can be like I mean many to many exchange rather than just
yeah,
talk on the
that's
call.
sharing the knowledge. That is the thing. We can do
Yeah.
what we can do, like lumbar spine. We want to do spine, we can do lumbar spine. Whether it's tumor there, whether it's a spine surgery, whether we do fixation, we are doing microdiscectomy. So we can find the material by patient to patient, and everybody can share their experience.
Okay. Sure, sir. Sir, we can at least we can do one experimental session and see how it goes, and then probably can decide if this thing can be like we institutionalize these master classes. Perhaps that can be a lot very beneficial, sir. So anything that you would like to add, and if anybody has any more questions to ask, please ask, or we can conclude the session. Sir, if you want to add anything, basically, sir, I wanted you to talk about one more area that millions of I mean, sorry, close to a million international patients come to India on medical visa alone, and on tourist visa, there might be more who get treated, and many of them, sir, they are coming through facilitators or agents. Many times they are misinformed also. If your doctor colleagues from Africa, like because they are the ones who are diagnosing that your disease is complex, you go to India or Turkey or Europe. So if they have access to doctors like you for referral and then guiding, isn't it a better modality compared to because many times agents or facilitators they misguide patients a lot. I mean, you must have seen it, sir. They come with unrealistic expectations also.
That is, the communication is more required, because for any query, I'm not saying the patient is coming to us or not. If they got any problem, they can discuss as a colleague with us.
Yeah.
That is because we can give number, they can do WhatsApp chat with us, they can send the reports, they can discuss what modality we should do, or they are planning to do. I am doing the same or different. They can discuss with us anytime.
No, no, sir. We are covering that in the Connect Clinic sessions. I mean, in the June, Dr. Ariba and Lavi, they have communicated your. They will discuss. They'll communicate your date also, so they can share the reports in advance, and we can through a Zoom session. Wherever it's a complex case, you can join, so they can present. So we are going to do that. So there's another question from Dr. Ivan. What are the current limitations of awake craniotomy and how are they being addressed?
Yeah, awake craniotomy we do when the tumor is in the eloquent areas, like in the motor areas or speech areas. But sometimes it's become very difficult. Last we have done in a one patient starts shaking during surgeries, and we have to just give complete anesthesia to that patient because patient cooperation is too much required during the awake craniotomy. For international patient, it's very difficult because the language barrier is there. Because patient should be, we
So,
try to
sir,
communicate.
in that case, then why is awake craniotomy done? Because, as
No,
you
no,
said,
some patient we discuss with the pre-op if they are happy with it. But because of the partial anesthesia or sedation, sometimes they behave abnormally.
okay,
That might happen. So I'm not very fond of doing awake craniotomies because they're very tough on the patient sometimes. Yeah, definitely. If the patient is in motor strip or some eloquent area where we want to. Now, what we are doing the functional mapping of that. We do functional MRI and we try to save those areas where these things are power remaining in the brain, localized to that. But
okay,
we do, especially Indian patient is easier for us because the language very because they are not communicating directly with me, they are communicating by anesthesia team, technician team, and others team. So sometimes we have to keep translator inside with the international patient to do that.
okay. Sir, if we have your permission, I think we can conclude the session for today. If you have any follow-up questions, please feel free to ask. Okay. There's a question from Dr. John Quete. Dr. Kansal, thanks a million for sharing with us your expertise. Surely we'll need to contact you anytime for advice and possibly referring patient to you for taking over because of infrastructure and less than 5% complications post-surgery. Thank you, Dr. John Quete. We like the work group we have with you as Dr. Anil specified, so rather than thinking of referring patient to India, we should think whether the situation is complex enough. We document the case file, relevant reports, we share it with Dr. Anil, and Dr. Anil will give his opinion, and then we evaluate whether the patient can be managed locally or whether they need to come to India. So, Soumya, I understand Soumya is your relationship manager. Whenever you have any case to discuss, please feel free to share, and the team will help you document it so that we share a well documented case dossier with Dr. Anil. Uh, Thanks everyone. Thanks a lot for joining us on a Sunday. I mean, for most doctors, Sunday is the only day they get for their family, and we keep you occupied with these master classes. Thanks a lot, and thanks Dr. Anil for taking time out. I know how busy your schedule is, and this is the second master class that you have done with us. Last one was in July 2025, and thanks a lot, sir. Uh, we will plan that session, that topic-wise session that you propose. We will plan that based on your availability. Thanks everyone. Thanks a lot for your time.
Thank you. Thank you very much. Bye bye.